Good morning, everyone, or guess good afternoon. I'm Victoria Weinstein. I'm the parish minister here at the Unitarian Universalist Church of Greater Lynn, and that is Chris Scheller, our minister of community life and learning, running our live stream and our tech. We have Melissa Stacy here from Compassion and Choices, and we have Sarah Elkins, who is the organizer for Compassion and Choices. As I said to all of you a few minutes ago, this is really a live taping of a resource that we are really happy to be able to share with all of you who are watching now, but also hello to those who will be watching later through Lynn Community Television and on our church website at UUCGL.org. And wherever you happen to catch this resource, we are recording on January 23rd, 2023 here in Swampscott. I also want to invite you to a follow-up event that we will be planning called Talking About Death Won't Kill You. And that will be led by a nurse advocate. And that will be a kind of a continuation of some of the things we'll be talking about this morning. I'd like to thank Chuck Francis. He's not here this morning, but he may be watching. He contacted me a while back about the medical aid in dying bill that is before the Massachusetts legislature. Chuck is a volunteer with the Unitarian Universalist Mass Action, which is a coalition of Unitarian Universalists in the Commonwealth who do social justice advocacy work. And Chuck was on the medical aid in dying action team. And he said, "Are you interested in supporting this?" And I said, "Absolutely." We're really happy to host this forum here at UUCGL. Death is perhaps the ultimate big question that we face as human beings. It's the one universal reality. Religious communities grapple with moral issues, and end-of-life decisions are among the most serious of those. So this is not just a medical issue, it's not just a political issue, it's about human agency and meaning and freedom, and it's about very difficult realities that a lot of people would rather not contemplate. In some religious traditions, only God can decide when a life should end. And you'll hear that. If you engage in this conversation, you will hear that from some who oppose the Medical Aid in Dying Options Act. But the beauty of freedom of religion is that people who have that belief can decide not to pursue that option at the end of their own lives. I've been a parish minister for 25 years, mostly in eastern Massachusetts. And I did my clinical pastoral training in the hospice setting. In fact, with Merrimack Valley Hospice, which is in North Andover. I wish that I could tell you from my long experience that palliative care and pain management are always able to ensure a peaceful dying experience, but that's not the fact. I can tell you that there are times when death is an agonizing process, despite the best of medical care. And that has always been true of all people, in every time and in every place. Loved ones seek desperately sometimes for a way to help their beloveds be released from their suffering. And sometimes they help them die. And they later suffer guilt and a sense of criminality for that compassionate act, for administering that high, merciful dose of morphine. Those with terminal illness, and I was going to say, I've heard a lot of those confessions over the years. You know, he wanted me to help him die, and I did, but it still feels like a huge burden of responsibility. Those who have terminal illnesses often tell me, "I'm not afraid to die, I'm just really anxious and scared about how much suffering I might have to endure and how much my loved ones will have to see me and how much that will cause them distress." If they could obtain a prescription from their doctor, they might choose to never take that prescription, but the sense of comfort that it gives them to know that they can is tremendous. And so finally, I would like to invoke the name and the presence of the Reverend Judy Wells, who was a very dear friend and colleague of mine who lived in Oregon, where the medical aid in dying option was available to her. Judy herself chronicled her experience with terminal cancer on the Caring Bridge website. Yeah, some of you are familiar with that. And when she became too ill to do that, her husband Dwayne journaled for her. And I read this from her obituary. With her body slowing down, and after the opportunity for final farewells with family and friends, Judy decided that it was time to go and proceeded to exercise Oregon's Death with Dignity option to hasten her death. She died peacefully and intentionally on September 28, 2020. It was the sort of gorgeous early fall day that we Pacific Northwesterners savor, bright and sunny with a breeze, cool and clear. Music was playing and there were flowers all around. As she took the medications that ended her life, she was surrounded by her daughters, her husband Dwayne, and a dear friend whom she had invited to, quote, be the designated calm person. Death came quickly and easily, just as she had planned. Judy wanted all of us, her colleagues and friends, to keep advocating for this option, and that's why I'm here. So thank you all for being here, for your courage in contemplating these most consequential of legislative issues. Thank you to our presenters. We'll have time, and those of us who are joining on the live stream, we want you to know that we will have time for question and answer following Melissa's presentation. And so whenever you like, you can submit questions into the chat on the Facebook live stream. And do you want to say anything about a website? Is there a website on there? Yeah, okay. And now I'll turn it over to Melissa. Thank you.
Thank you very much for that introduction and for your comments. I hadn't heard Judy's story before, and that was incredible. That's the death we all want. So thank you. So my name is Melissa Stacy. I am the Regional Advocacy Manager for Compassion and Choices in the Northeast, with a particular focus here in Massachusetts on this legislation. So Compassion and Choices is a national organization that is really focused on ensuring that everyone has access to the end of life that they want, regardless, period. It is the end of life choices that they want. And it can be, you know, if you want to be taken care of and have every medical option available to you right up until the end, that is what you should have. Or if you want more of an option like medical aid in dying, we believe that that is what you should have. We also focus heavily on end-of-life planning, because as we age or as we get sick and we become terminal, sometimes we can't express our wishes and values to our family and friends and loved ones. And so doing the planning and writing down intentionally what you would like to do is really important, and we have some resources we're going to share in a few minutes that I will share with you. So, as we begin, I want to share a small story with you about one of our patient advocates. On the screen is Lee Marshall from Gloucester, Massachusetts. This is her testifying live via Zoom at the Joint Committee on Public Health in October of 2021. So Lee is and has been a patient advocate since prior to 2018 in her diagnosis of cancer. She has a background in psychology and is well aware of what her disease will do and what her end would look like. In January of 2022, Lee was told by her physicians that she no longer was responding to the treatment for her terminal illness, and that there was nothing else that they could do medically other than work to keep her comfortable. Lee very much wanted to die at home, in her home of 30 years with her husband, and peacefully in her husband's arms. Unfortunately, at the time, and currently, Massachusetts doesn't have that option legally. And so she made plans to move to New Mexico, which does have that option. And they made the move in February of 2022, and she ingested in March. In talking with Lee's husband after the fact, Paul shared that Lee had a miserable month leading up to her death. The move was incredibly difficult and painful, flying across country for someone with cancer. She was ill. They had issues with the place that they had leased to stay. Pretty much every aspect of it was exhausting for her. And she was very angry that she had to leave her home of 30 years, her familiar surroundings, and go to a brand new place. I am happy to share that Lee's final wish to die asleep in Paul's arms did happen. And that was, she ingested the medication, fell asleep, and died peacefully about 45 minutes later. And he said that was the blessing of the trip. Everything else was just horrible. And he is very angry, and she was very angry at having to leave their home. So that's what we're working on. That's why we're working on this for people like Lee. And so I want to talk a little bit about where we are as a society in the fix-it healthcare system. We know we can do better. Physicians are not comfortable talking about death. Doctors are not comfortable talking about death. We as a society are not comfortable at talking about death. And yet, as Victoria stated, it's the inevitable. None of us get out of here alive. And if we plan so much for other aspects of our lives, we really need to plan for death, which is a guaranteed aspect. So we know that we have a fix-it healthcare system. Everything is focused on getting the patient better, getting the patient moving again, getting the patient back into their lives. And there comes a point when you are ill, terminally ill, that is not possible anymore, that there's nothing more the fix-it healthcare system can do. And we have to find that acceptance of it is not what can I do to get better, it is now what can I do to have the best quality of life for me for now until the end, and what do I want my death to look like? What values do I want to carry into that? And so some of that, finding that acceptance, is taking a really hard look at what type of comorbidities do I have? What is my mobility looking like? What pieces have I been losing? Have I had a number of hospitalizations? Because you can be terminally ill without a 6-month prognosis for a very long period of time, but there comes a point that that disease will kill you. And you need to decide what you want and when that is to move forward. So within the healthcare system, you have a lot of options once you come to that acceptance, how to move forward. And there are a number of end-of-life treatment options. I think, though, we mostly tend to focus on the top one, the pursuing life-sustaining treatment. A lot of times that is what medical professionals, because they want to fix you, because they hear your voice that you're not ready to go, that they want to do what they can, they get stuck in this area. So we as patients have other options that we can say, no, this is what I want to do. We all have the option to refuse treatment. We don't want to do this. We all have the option to discontinue treatment, to say, okay, I took this on, it's too much for my body, I can't take this, and I'm done, I don't want to do this anymore. It could also be that it may not be too much for my body, but this particular medication doesn't make me feel good. I don't feel myself. I'm a little foggy. This isn't what I want to do. You can stop any treatment at any time. Usually when you do that, that leads into hospice and palliative care at the end of life. And hospice is an incredible, incredible thing for patients who are at the end, and keeping them comfortable through that but it cannot and does not cover all aspects of pain and suffering, because it's not just physical pain we're talking about. There's other methods of suffering. Voluntary stopping eating or drinking, or VSED, is usually an option that we recommend you wait for until you're on hospice, or at least have support, because that is not an easy thing to do at the end. And then palliative sedation is also there, where the patient will be given enough medication to basically put them in a medically induced coma. But even then, we don't know that all of the suffering is taken care of. When I talk about other suffering, we have a really impactful story just this morning from a volunteer. Her former husband had esophageal cancer, and he wasn't in pain, but the last months of his life, he was very focused on the fact that one of the ways he could die was choking to death on his own saliva. And so while the physical pain wasn't there, he was bedridden, laying there, and all he could think about that at any time, I can die choking to death. And he would have much preferred this option had it been available. He did not die that way, I'm happy to report, but it was there, and that is a form of suffering that is not the physical pain. And then the other option that we're going to talk about today is medical aid in dying. And we're going to talk a little bit about what that is and the legislation here in Massachusetts that we're working on. So as I get started, I always like to clarify and make sure we're all on the same page, so you know what I'm talking about when I talk about medical aid in dying. And it really is the ability of someone who is terminally ill with a prognosis of 6 months or less to live, which is also the general qualifications for hospice care, an adult here in Massachusetts that can ask their doctor for a prescription that they can take themselves that will bring about a peaceful death if they choose. And you're gonna probably get sick of me saying the words option and choice, but we really wanna be clear that this is not a mandate. This is something that is a very individual and very personal choice that people have, and we just wanna make sure that that option is available. So in addition to let's define medical aid in dying, let's talk about what it isn't and define that right off the bat. So you often hear it referred to as physician-assisted suicide, as suicide, or as euthanasia. It is none of those pieces. The American Academy of Suicidology has stated very clearly that medical aid in dying is not within their purview. Suicide is the ending of a life that has potential. And usually it's a very secret ending of a life. Medical aid in dying is the end of a life that is already coming to an end. The person the patient is terminal. There is no option. And many times patients want to live. They don't want to die. Sarah and I talk with advocates all the time that want to be here as long as possible and soak up every second they can with family and friends. And unfortunately, their illness will kill them, and that is the reality. And so there's fundamental differences. The other piece is that medical aid in dying is a process that is talked about. You have to talk with your medical professional about this. They have to share with you all of the end-of-life options available in addition to medical aid in dying. We really encourage you to talk to your friends and family, whether that's your family of origin or your chosen family, to let them know what your wishes are and talk through it. Most patients have done a ton of research about this. This is not a decision that takes place quietly. And euthanasia, in its simplest definition, is someone else taking the action for the patient. In medical aid in dying, the patient has to be the one to self-ingest. Someone else cannot put the medication in them, cannot inject it in any way. There has to be a self-affirming action. The other thing that I'd just like to share is that medical aid in dying is also not any commentary on hospice or palliative care. A lot of times we hear that people are like, well, if you would invest more in palliative care, if you would invest more in hospice and make it more broadly available, people wouldn't want this option. That is not the case. Hospice and palliative care are two incredibly compassionate medical practices that are vital. And in fact, the majority of people who choose medical aid in dying are already, in fact, on hospice. Hospice can't cover everything. It can't cover all the pain. It can't take care of all the suffering, regardless of how good it is. And so this is not a failure. It works in conjunction with. And we also know that in states that have medical aid in dying, hospice and palliative care is used more because the doctors have to talk about it more as option in those end of life. And so it tends to be more heavily used by patients at their end of life. So where do we stand in Massachusetts? What's happening here with the population? So in 2019, just before the pandemic hit, we did a poll, and it showed that 70% of Massachusetts residents supported the option of medical aid in dying. We did a small poll at the beginning of 2022 just to see where things were, and that number had gone from 70% to 77%. It doesn't mean that 77% of residents want the option for themselves. They just feel that it should be available in Massachusetts should somebody want the option to use it. The other thing we're seeing, and this is in Mass but across the country, is a growing support among medical professionals for medical aid in dying. The American Medical Association, in their code of ethics, states that it is up to the individual physician whether or not that they want to participate in medical aid in dying where it is legally authorized. And in Massachusetts, the Massachusetts Medical Society has a position of engaged neutrality, which means they are neither for nor opposed, but if doctors ask about it, they will educate the physicians on what aid in dying is and how to practice it should they choose. So, and that stance of engaged neutrality was reaffirmed by a 4-to-1 vote just this past May. We have a lot of information. Medical aid in dying has been around in the United States since 1997. Oregon was the first state to pass it. It says 94 on there. That's when it was passed. It took them 3 years to implement it and get the bill moving. Since then, we have a total of 10 states, and we call it one jurisdiction, which is Washington, D.C., that has authorized medical aid in dying. And you can see the years through there. I like to point out, because, New England, right? 2013, Vermont was the first state to pass medical aid in dying through the legislative process. The first 2 states passed it through ballot initiatives, and Montana passed it through state Supreme Court. And since then, the majority has been passed through the legislative process, right up through, and New Mexico was the most recent. In that 25 years, we have learned a lot of information. We know for a fact that prescriptions for medical aid in dying provide comfort. About a third of people who request the prescription actually never ingest it. They never take it. They qualify, they go through the entire process, and it's lengthy, and we'll get to it. But they never ingest it because simply having it gave them the peace of mind to know that if I wake up today and today is going to be the best day of the rest of my life and I can't do today, then I know I have that option. I have that choice available to me. And so they don't ingest. Only about 2/3 do. Pain is not the only option and the only reason people want this as an option. There are many different reasons as individual as the choice to actually ask for medical aid in dying, but it's anything from fear of the unknown to pain to suffering to this disease has taken everything else from me. I want to know that I have the final decision at the end. And we know that there has been no substantiated instances of abuse or coercion of anyone in the 25 years that this has been law in the United States, in various states. that's something we hear very frequently, is that people are going to be pushed into doing this, that family members are not going to want to take care of them anymore, and that they want to be free of that quote unquote burden. Patients are not burdens, and people are not burdens, and there has not been a single instance after an investigation where anyone has said, yes, I was coerced, and they were coerced into this. There's been no instances of that at all. And so it's really important to point that out because of the safeguards in the legislation, because the patient has to self-ingest, and there's a number of checkpoints with medical professionals to ensure that this is the patient's decision. Those fears have never come to fruition. So this is updated as of the end of 2022, is the most recent data. A majority of the 11 jurisdictions do mandate reporting. The Massachusetts bill includes it as well. So you can see in 25 years, 6,378 people have actually ingested the medication. So if you think about that over 25 years in 11 jurisdictions, that's not a lot of people. It is less than 1% of people who die on average in a state that actually request the option and utilize the option of medical aid in dying. But as I mentioned earlier, it has a ripple effect because while it impacts those patients immensely because they are suffering, they're suffering in pain, it also encourages and educates our medical professionals to talk about death with their patients, to plan for it, and to ensure that they have the options available to them. And so that, as we said, increases use of palliative care and hospice across the states that medical aid in dying is authorized in. So what is a patient, terminally ill patient who's requesting this? Like, what do we know? What are some of the data pieces about who they are? The majority of them are over the age of 65, but age is not a single qualifying factor for accessing medical aid in dying. You have to have a terminal illness and a prognosis of 6 months. It is equally male and female. There's some of the reasons there that we talked about: the loss of autonomy, reduced quality of life, the fear of pain and suffering and what it could look like. 82% of people who request this, of terminally ill patients who request this, either have cancer or some other neurodegenerative disease like ALS. Most of them, about 87%, are on a hospice and receiving care at home, and 90% of patients who requested and ingested were able to die at home, which we know that that is the majority of what people want. So the legislation here in Massachusetts is based on that original Oregon bill. There's been some changes, but we have some very specific eligibility requirements. The person has to be an adult, which means they have to be over the age of 18. They have to have a terminal diagnosis, which means a disease that will kill them, with a prognosis of 6 months or less to live, about 6 months or less to live, which is the hospice eligible piece, and they have to be able to make an informed decision. This is something that's really important because, again, it goes back to that personal autonomy and the patient's choice on whether this is something they want or not. So, as I said, there's a number of safeguards in this, and that includes the request requirements. The patient has to make an oral request to their physician for medical aid in dying. They have to follow that up by a form request that's witnessed by 2 people. And this form is really important because the 2 people witnessing have to say they're not being coerced in any way. They understand the decision that they're making, but one of those people cannot be a family member or someone who stands to gain from the person's death. And so again, that goes back to that coercion piece. We need to make sure there's a checkpoint in place that people aren't being coerced for some financial reasons. And then these requests have to be 15 days apart, because again, it's to give a little bit of time to make sure that the patient is not making this request quickly. We know that that doesn't happen, but it's a check, it's a safeguard just to make sure. There are a couple of different physicians involved in this process. So the first is your attending physician, which is normally your primary care provider, someone that knows you, that you've been working with or been taking care of you for a long period of time. They are responsible for ensuring that you are eligible, so all of those pieces, that you're an adult, that you are mentally capable of making the decision and you understand it. They have to go through every single end-of-life option that is available to you and make sure that you understand all of those options and talk through them, answer any questions you have, including medical aid in dying. They have to make sure that you're not being coerced. They have to make sure that your prognosis and diagnosis diagnosis and prognosis are accurate. And then they will connect you to a consulting physician who has to do the same thing. They go through, make sure that you meet the eligibility requirements, make sure that you understand the choice that you are making and what the outcome will be, and that you're not being coerced. And then in the Massachusetts legislation, there is a third doctor involved, and this is a mental health professional, licensed mental health professional in Massachusetts. So it could be a psychiatrist or psychologist, or a licensed clinical social worker that needs to provide counseling, at least one counseling session with you as the patient, to make sure that, again, you understand the decision that you're making when it comes to this medication. And then once that happens, and only after those 3 steps have taken and you submit your written request form, can the doctor write the prescription for the medical aid in dying medication. The doctor, the attending physician, is also responsible for charting your request and making sure that your initial request, the oral one, is documented, documenting the different steps along the way, etc., and then reporting information on an annual basis to the state of Massachusetts, because the bill requires that the state collect the data from all prescribing physicians and issue a report. And it's just another, again, area of safeguards to ensure that the processes and procedures laid out in the legislation are being followed and the safeguards they are working as intended. Some additional key protections that are built into the legislation, and we've talked about the self-ingestion, and I want to go into it a little bit more. The patient has to be able to swallow the medication, either by holding a cup or through a straw. A caregiver can, it's a powder form, so the caregiver can mix the powder into about 4 ounces of liquid and hold a cup for the patient that has a straw in it, but the patient has to swallow themselves. If the patient has a feeding tube and can't swallow, it can go into the feeding tube. Again, caregiver could load it, but the patient has to physically push it through the feeding tube. It's that last final act of, this is my will, doing this. The death certificate is filled out, and the cause of death is listed as the underlying illness, not medical aid in dying. That helps with standard practice of care, but it also helps with reporting and data in regards to like cancer deaths and pieces like that. And your life insurance as the patient cannot be rejected. And it is still must go to your family or whoever you've designated, simply because you've ingested medical aid in dying. This is not suicide, and so it doesn't impact your life insurance in any way. One of the other key protections is that it's optional for everyone involved. So we've talked a lot about the patient's decision, right? This is bodily autonomy. This is the patient's choice. But no medical professional at any level has to participate in medical aid in dying. It is 100% optional for doctors as well. There are no repercussions if a doctor says, no, this is not something that I feel comfortable with, I don't want to participate. They simply have to refer their patient to another physician. The same with medical systems. There are medical systems that are, this is against our core beliefs or our mission. It is not required that they participate or their doctors participate in this, and that goes down to any nurse that is caring for a patient that wants this option, and it goes to the pharmacist as well, filling the prescription. And so anyone at any time can say, this is not something I want to participate in, with no repercussions. They simply have to follow standard of care and make sure that their patient is referred to a different physician or has a different option. And there is no liability for medical providers who participate in this under the law. So if you're acting in good faith, there is no liability, and you can't be sued by a family member who may not have agreed with the patient's decision to ask for this option. So we talked a little bit about what the medication looks like, but the dosage and type of medication is really up to the doctor, who knows the patient, who knows the other medications the patient's on, maybe some of the patient's comorbidities. It's the doctor's choice on what prescription to prescribe. It is made in a compounding pharmacy into powder, and as I said, you can ingest it in about 4 ounces of liquid. After self-ingesting the medication, the patient falls asleep, usually within about 20 minutes, and then dies within 1 to 2 hours of ingesting the medication peacefully. So the federal law, there's a federal law that was enacted in 1997 in reaction to Oregon that states that medical aid in dying cannot be paid for by federal government funds. And so Medicare will not pay for the prescription, Medicaid or Mass Health will not cover the prescription costs, and veterans benefits will not. Most private insurance will pay for it because it's just a general prescription. And there are a few states, California being one of them, where the state has allocated their Medicaid funds, not the federal government's funds, to pay for prescriptions for people on the state Medicaid who want to utilize this option. So here in Massachusetts, we have the bill that we've been talking about that has been filed for, now I gotta do math. It's been filed every year in some iteration since 2008. So a very long time. In 2012, so is that 14 years, right? So in 2012, there was a ballot initiative in Massachusetts. In the last 2 weeks of the campaign, we were outspent by a 5-to-1 margin with fear-based ads. And it lost by a margin of 51 to 49%, which is really incredible. If you think about being outspent 5-to-1, you would think that the number would be much larger. Since that time, the medical society has gone from opposed to neutral. We've seen public support for this go from in the low 60s up to that 77%. There's been a lot of changes in our society since 2012. And so we are filing the bill. Our Senate champion is Senator Joe Comerford, and our House champion is Representative Jim O'Day. He's in leadership, and they are championing the bills. Right now, you'll see the bill numbers up there. So currently, it's SD 265 and HD 2342. Don't memorize those numbers. They will change as soon as the bill is assigned to committee, which we expect in the next couple of weeks to a month. It'll most likely go to the Joint Committee on Public Health. So those will change. You can still search on the Massachusetts website by them, but the bills are almost identical to what was filed last year. There's been some minor technical changes just to kind of update the bill a little bit, but none of the safeguards, none of the core of the bill has been edited or changed. And we are working to pass this session. We've gained a lot of momentum over the past few years with medical aid in dying. We ended the 2022 session with more co-sponsors in the House and Senate than we have ever had. We're continuing those conversations, and so we're really encouraging advocates or people that are interested just to reach out to your lawmakers and say, hey, I support this, because it's going to be those voices and those stories that lawmakers then take to leadership and say, hey, we need to move this now, that keeps the bill relevant and moving in the public space. So in addition to some of the resources, Sarah, I didn't fix that slide, I apologize. In addition to some of the resources you see here, we also have some handouts. Everything that we have with us is available online in a digital version for those of you that are watching on Facebook, currently live, or maybe watching the recording later on the Access channel. Everything that's back there can be found on compassionandchoices.org or compassionandchoices.org/Massachusetts. But I want to walk through some of it. We have a bill summary that talks about what's in the bill and who to contact and some of the key safeguards and points that are in there. We have information on how to look up your lawmaker and your legislator. I will also say that we have some incredible resources that are not related to the medical aid in dying bill, but that you may be interested in. We have a booklet that talks through how to do an advance directive. We have a dementia tool that you can log on if you are worried about a dementia diagnosis in your healthcare as you proceed through one, or if you've been newly diagnosed with dementia. Walk through and talk about at what stage do I want you to stop giving me my heart medication? At what stage do I want you to stop trying to get me to eat? And it could be at any stage. It could be at, no, I want you to consistently do that. But it gives you the ability to walk through the dementia decoder and then print it off and give a copy to your family and friends, or to give a copy to your doctor or your medical professional or your lawyer, whoever is holding on to your will and wishes. We have at compassionandchoices.org/EOLC, it's our end of life consultation line. And this is an incredible tool you can call. And within 48 hours, someone will call you back and they can help you talk through what you want your end of life to look like. What are your values? What are you looking to do if you live in a state of Massachusetts and you are terminally ill and you know you want to plan to move to a state well advanced of when you get that terminal prognosis? They can walk through that with you as well, so you know you have aid in dying available to you. So that's a really great resource. And then both mine and Sarah's emails are there as well. And that's, I'm M. Stacy. Sarah is S. Elkins, E-L-K-I-N-S. And we're both at compassionandchoices.org. That's our direct email address. And we welcome anyone reaching out looking for information, whether it's about the legislation itself, ways you can get involved. Sarah does an amazing weekly update on what's going on and ways you can take action. We have some monthly online action alerts available that you can reach out and ask to get added on, or just simply, hey, what can I do today? I have 5 minutes. What can I do today that might move this bill forward? So with that, I am going to pause and see if we have any questions. And I'm looking at Chris and Victoria. Do we want to start in the room or do we want to start online?
Sure, let's start in the room.
Okay, perfect. And I am going to warn you, I'm going to walk up to you with a microphone, because in order for people online to hear, I need you to talk into the microphone.
My question is about the time frame. What would be the best case scenario, still realistic, for this to become law in Massachusetts?
It's a really hard question, and that is the million dollar question. If things were to move perfectly, it could be passed this year, 2023. We are just starting a new legislative session. It takes some time for the legislators to assign committees, to establish the rules, those types of things. But we could, and are asking for a hearing in early hearing this year. So instead of waiting till the fall, trying to get something in the summer. So it could move quickly, realistically, for it to be passed into law, but it's really going to depend on, conversations happening externally. So letters to the editor, articles in the paper, things that keep the bill relevant and moving forward, and people reaching out to their legislators and encouraging them to talk to each other and say, hey, I support this. Do you support this? Okay, let's talk to our leadership. So it's, unfortunately, there's no crystal ball, so I know that that's not the answer you were looking for, but unfortunately, that's kind of where we are right now.
I presume you know who would vote for it and who would vote against it.
We keep track, so as people have those conversations with lawmakers, we know who our bill sponsors were from last year. We're working on getting them back, our co-sponsors back engaged for this session now that the bills are filed. And we have a pretty good idea of where we are. And we know that the majority of the legislature, both the House and the Senate, support this.
I ask the question because I hear you saying, oh, talk to your legislator and so forth. But that seems to be, that seems to be a very broad approach. If we knew who the problem people were, that seemed to be a better target than simply calling my own who I know would be for it. Are you at liberty to say where the problem might be in the legislature?
So again, that's a really good question, and that's not one that I can talk about. It's not it is a broader than one individual problem, if that makes sense. And yes, it seems like a very broad approach to reach out to all lawmakers. What I can say is we know what legislators are supportive, which legislators are supportive, and which ones either are not or which ones we don't know, because there's a lot of question marks. We have a lot of new lawmakers that have come in this year. And so that is where I would say reach out to Sarah or myself, and we can have that individual conversation and say, hey, we know where these lawmakers stand. Yes, that's your legislator. Great, they're supportive. Maybe you could reach out to a few of these few. Or you may say, well, great, my lawmaker has an awesome relationship with XYZ. I'll ask them to reach out to their colleague and have a conversation. And so that's where I think a little more individual one-on-one conversation would be great.
Melissa, do you have on your website a roster of like the last vote, these are how the vote, you know what I mean? You know what I'm saying.
I do.
Yeah. Okay.
So we do have a link to the bills on our website, and that links directly to the co-sponsorship page on the Massachusetts legislative website. And so right now, if you were to look up SD 265 and HD 2342, you wouldn't see a lot of names because the bills were just filed, and so we're in the process of doing that. What you will see from our website is links to last year's bill, and you will see the 68, 69 House members that were co-sponsors and the 20-ish senators that were co-sponsors. So those will be there, and those will continue, those will continue to be updated throughout the year as we add co-sponsors to it.
You don't have a roster of the nay votes.
No, because we haven't had a vote. And that's been the piece, right? So the bill has been filed, but there's not a public vote roster. It hasn't come to either the House or the Senate floor for a full vote. The Committee of Public Health voted to move it forward, but again, that is not that's not something I have access to, and that's a small subset. Yeah. So unfortunately, until a vote takes place in either the House or the Senate, we can't look at that. That's a really good question. Any others? Anything on social? Okay. All right. Well, I just want to say thank you all very much for the opportunity. Thank you for coming. Thanks to everyone who's watching. I hope I didn't make you seasick moving around too much. But please reach out to myself, reach out to Sarah if you think of other things moving forward. We are always happy to have conversations and answer questions. So thank you very much. Thanks for having me.
And I just want to encourage you all, because you all intersect with multiple communities, I assume. You know, you have friends, you have families. Talk about it with them. Talk about it if you're part of a faith community and you can, and direct them towards the resources, because that is how a lot of things get moving and get support. And talk to your neighbors. People don't even know that this is happening, that there is that this has been stuck in committee for a really long time, and so just letting people know that, did you know, is really helpful. So that's it for me. Thank you all so much. Thank you, and thanks, Melissa. Yeah, and thanks, Chris.
Thanks for the opportunity.